Right, well, thank you everybody very much for joining this evening. This is a webinar around maximising success in the delivery of nationally commissioned services. So the audience for today is pharmacists and their teams. My name is Alison Scowcroft. I'm Community Pharmacy Clinical Lead for NHS Greater Manchester, and I'm joined by my colleagues Ali Calaf, who's Project Manager for NHS Greater Manchester, Diane Murphy, who is Programme Manager for NHS Greater Manchester Nationally Commissioned Services, Louise Gatley, who is Director of Services for GMLPC, and Lovejoy Kandula, who is Director of Pharmacy Transformation for GMLPC. So just a note, today's webinar is hosted by Greater Manchester Healthcare Academy. This academy is a partnership between NHS GM, GM Healthcare Partners and Community Pharmacy. And the focus is engaging and supporting community pharmacists to achieve their full potential in service delivery. We do run a range of training events, although it's been noted we haven't run one for a little while because things have been pretty busy this year. And we do work to support the whole pharmacy team with bespoke training, particularly around service delivery and improving patient outcomes. The Academy is a partnership between NHS Greater Manchester, GM Pharmacy Local Professional Network, Greater Manchester LPEC and CHL, which is the provider company for Greater Manchester, and supported by CPPE. So just a quick note from the Academy around community pharmacy service delivery. So it's really important that we are delivering so that we can demonstrate to the system our full potential as a sector. GM Healthcare Academy and GMLPC is supporting contractors and pharmacy teams to embrace the services that we're commissioned to deliver. So we really need all pharmacists to step up and embrace these new service opportunities and deliver what we promise, or else we do risk services being decommissioned and loss of funding. It's really important that we work together to demonstrate community pharmacy's value and credibility as a provider of health and care. And just to let you know that there is some performance management ongoing of some of the services that are delivered. So CHL are involved with some of the locally commissioned services, and the NHS Greater Manchester programme team are looking at farm outcomes data for the nationally commissioned services. We're in Zoom this evening, so if everybody can just mute themselves, please, just to make sure there's no interference with the presentation. We will have plenty of time for questions at the end, but if something does come up throughout the presentation, then you can put a question in the chat and somebody will be monitoring that throughout the presentation. But if you'd rather save your questions till the end, then please do so. You can come on camera and come and talk to us if that's what you want to do. So in terms of the agenda, I'm going to give you a little bit of context and background. I'll then hand over to Lovejoy, who'll talk a little bit about managing pressures and workload. Back to me to talk about things that are common to all services. And then I'll hand over to Louise to talk about DMS and hypertension case finding. Diane will cover CPCS and smoking cessation service. And then we'll give you a very brief update on the contraception service and then open up to any Q&A at the end. So let's just give you a little bit of context and background. So as we know, we're in the year 4 of the Community Pharmacy Contractual Framework, which is a 5-year deal that was agreed by Community Pharmacy England back in 2018-2019. And the focus of the Community Pharmacy Contractual Framework was all around expanding clinical service delivery. So as you know, we've had a number of different services which have been introduced in the last few years, particularly around expanding clinical service delivery in community pharmacy and supporting the NHS long-term plan. So a number of new services have been nationally commissioned, and we've found that they've quite often landed at times that were extremely pressured in community pharmacy. For example, CPCS being launched in the run-up to winter. This year in 2023, a new nationally funded leadership role was recruited, the Community Pharmacy Clinical Lead, that's myself. And the main focus of the Community Pharmacy Clinical Lead role is to support pharmacy integration within Greater Manchester, with a particular focus on nationally commissioned services and demonstrating the role that community pharmacy plays to the wider healthcare system. Following some really successful influencing and negotiation by the Community Pharmacy Provider Board, CPPB, we also managed to secure some funding for some additional resource to support the delivery of the nationally commissioned services in GM, and a programme team was recruited to support this. So that's Ali and Diane who are on the call this evening. So with this new resource, we've therefore started to have the capacity to be able to analyse the service data in farm outcomes to really understand how GM community pharmacies are delivering nationally commissioned services. We're particularly looking at compliance to the service specification and the quality of the delivery of these services. And so, following a comprehensive review of this data, we have identified some themes and trends that we want to share with you this evening to help you to maximise your success in service delivery and to make sure that you're meeting your contractual requirements. And most importantly, make sure that you're supporting your patients appropriately and demonstrating the value that community pharmacy brings to Greater Manchester citizens. This next slide is a little bit busy, but we wanted to include this because there's some really powerful messages in here. So we've done a little bit of work, and I can't take the credit for this. This was my colleague Ali, who's looked at the data for the month of June. So we've looked at all of the referrals that came into DMS, GP CPCS and hypertension case finding services in the month of June. We've then looked at the claims that were made to the BSA in the month of June for those services. And it's really clear to see that actually pharmacies in Greater Manchester are missing out on a significant amount of income. So for GP CPCS and hypertension case finding, there's almost £43,000 worth of service income that could have been claimed by GM pharmacies if all those referrals that were sent for those services were picked up and actioned appropriately. Some particular ones to highlight around DMS, given that DMS is an essential service and not an advanced service. If all 3 stages of DMS were completed on farm outcomes for the month of June, over £100,000 could have been earned for community pharmacy in Greater Manchester. So there's some significant income to be made from these services. I know there's been a transition away from focusing on dispensing activity and towards more service delivery, service-focused delivery. But as I said, we're not doing what we need to do in terms of ensuring that we're delivering these services appropriately. And the most important thing to remember is this is not necessarily all about the money. This is all about your patients. So all of these numbers in red of referrals that haven't been picked up, whilst that is lost income, that's also patients who've been referred to the pharmacy, to your pharmacy, expecting you to contact them to follow up this service delivery, and those patients haven't been followed up. So just really wanted to bring this slide to the forefront of your minds to make you think about potential lost income, but also those patients who potentially are not being cared for through these services that are referred into community pharmacy. So why is service delivery important? I'm sure that we're preaching to the converted with this one. You may have already heard recently of the Primary Care Access Recovery Plan, which came out early in the summer. That outlines a key role for community pharmacy to support general practice and save appointments, particularly through expanding the hypertension case finding service and the oral contraception service, and also the introduction of a new common conditions service, which is nationally commissioned PGDs for minor ailments, for example, impetigo. So the Common Conditions Service is coming at some point in the next few months, unsure of when the landing date is, but that's a big part of the Primary Care Access Recovery Plan. There's an increasing reliance on community pharmacy teams to support and maximise our service delivery, and how we work in an integrated manner with general practice, secondary care, urgent and emergency care, cure teams in hospitals. This is a key enabler to make sure that community pharmacy is recognised and valued as a partner within the NHS. So the contribution engagement of you guys as pharmacists and your teams in service delivery is a critical success factor. I'm going to hand over to Lovejoy now to cover managing pressures and workload.
Thank you, Alison. And after sharing that extremely compelling data, I think that we'll move on to talking about the current pressures and workload that community pharmacy are facing. So we do understand that these are very, very challenging times for contractors, pharmacists and pharmacy teams. And I just wanted to take this opportunity to provide assurance that the Community Pharmacy Provider Board, GMLPC colleagues and all the colleagues that work together on delivery of services here, we do provide regular updates and information to the GM Integrated Care System to ensure that your financial, operational and workforce pressures are being understood by the system. We've also engaged with MPs and have written to them many, many times over the last 3 or 4 years. And we also engage with Greater Manchester Health Watch to ensure that they lobby and support community pharmacy as a sector on behalf of Greater Manchester. So just in terms of some current work, we have got some work to develop GP and pharmacy interface working principles. The principles are agreed now, but we want to use this as an opportunity to work with general practice colleagues and the ICS to develop understanding, save you time and reduce the administrative burden that you're facing. I've just written a paper on addressing medicines shortages to raise awareness of the challenges that you have to get the medication supply, how it impacts patients, and what is it that Greater Manchester can do to help us. We're also in the process of developing some workforce schemes to support recruitment, retention and well-being. For example, we're looking at apprenticeship schemes. We're looking at collecting primary care workforce data so that we can actually put a business case forward to help fund any courses and actually support recruitment through fairs, etc. And we've also recently started a project to roll out access to the full GM care record, which will allow read-only access to GP and hospital records to save time and find information easily without you having to contact other healthcare professionals in the system. Next slide. So in terms of well-being, I have spoken to many of you over the last few months, as of my colleagues are on the call, and we understand that it's a really critical time to support you with your well-being, particularly your physical and mental health and well-being. So Community Pharmacy Provider Board have acquired access to a suite of health and well-being resources now for pharmacy teams alongside wider primary care. We have just developed a one-page infographic to make it easy for you to access that information and whatever support you need. You can contact pharmacist support for advice, and also the GMLPC team have now completed the mental health first aiders course to enable us to support you better in these challenging times. Next slide, thank you. So in terms of the workforce wellbeing support, we will share this offline and I will put a link in the chat, but you can see there's a range of free and confidential resources now available to support you. We start off with crisis support, which is the immediate support that you might need should any of you or your colleagues be suffering mentally or require immediate assistance. We've got an NHS staff mental health hotline. There's a resilience hub. We've also got a toolkit that you can use with your pharmacy teams. There's a self-check tool. There are downloadable apps that are free for you to use now. There's also look after you coaching support. So if you want something a bit more long-term, then you've got that access now to that sort of support. We've also got financial wellbeing, cost of living support advice, and also just the general rest, rehydrate, refuel, and general guidance and tools that you can use with your pharmacy to make sure they stay resilient and stay well. We understand that it is very pressured on a financial basis. We understand operationally it's challenging. We also understand that this has a severe impact on the workforce attrition as well. But we are working really hard on your behalf. So we ask you to take the following into consideration, what we're going to talk about today to help you remain sustainable. Next slide. So just as a starter for 10, that's what we're trying to do for you. But what can you do to help yourselves and help your teams? It's really important to start planning your workload with your team now. I mean, the priorities are numerous, and we know that you're challenged with many, many different priorities every day, but it's really important to ensure that workload is shared with members of your team. Talk to someone if you need support or help. It's really, really good to talk. It's really good to get things out of your system. If you need to talk to the LPC, please contact us if you want to speak to someone in your team, or you can access the wellbeing resources and numbers that we've provided to you. Make sure you keep adequately hydrated, make sure you get a good sleep, make sure you get fresh air and exercise, and take time every day to do something to relax. Self-care is really important. We need to ensure we're all checking in regularly with each other to check how everyone is coping and feeling. And talking with someone who listens is a rapid stress reliever and improves well-being. Thank you very much. And I'll hand over to Louise. Thank you.
Thanks, Lovejet. So what we wanted to do was just pull out a few themes that are common to all of the nationally commissioned services and cover those first, and then we'll go into each of the services in a little bit more detail. So some of the things that are common to every service is your pharmacy team. As pharmacists, you are not alone in delivering these services. As Lovejoy said, it's really important that you involve your team and support the workload for the nationally commissioned services. So your team should be checking farm outcomes regularly, and they should be alerting the pharmacist, including locums, to any referrals that have come in and need action. It shouldn't be the pharmacist's responsibility. You've got an awful lot on your plate as a pharmacist, so use your team to check farm outcomes. You should be checking that at least twice a day, if not more. You should make sure that all your staff have got access to both NHS mail, shared mailbox, and farm outcomes, so that they can support you with identifying any referrals that have come in. We're seeing a common theme around locums, particularly using the fact that they're a locum as an excuse not to deliver some of the nationally commissioned services. If your pharmacy is commissioned to deliver a service that's nationally commissioned, then the contractor should be ensuring that locums are delivering those services, particularly those such as DMS and CPCS, where there is a requirement to respond to that referral within a certain amount of time, and where they are very commonly commissioned across Greater Manchester, and obviously DMS being an essential service. So locums should be getting involved and should be delivering these services. And the services that you're commissioned to deliver must be delivered throughout your pharmacy opening hours. Smoking cessation, hypertension, case finding, and contraception might be slightly different with respect to locums, but actually there's no reason that a locum can't deliver any of those services. Accepting referrals in farm outcomes is a really good one. As I mentioned earlier, the programme team are looking at the farm outcomes data on a regular basis. They're identifying any referrals that are sitting at referred status, and that means that no action's been taken. So if you've seen a referral and you're doing something with it, you're in the process of contacting the patient to follow up that referral, then please press accept in farm outcomes. That tells us that you've seen the referral, you're doing something with it. It puts it into a pending state. And please remember that everything that you type in farm outcomes is visible to the person who referred that patient. So for smoking cessation service referrals, the cure team at the hospital can see everything that you've entered. GP CPCS referrals, same again. The general practice can see all the data that you've entered. They have access to that through farm outcomes. So anything that you enter into farm outcomes, including your rejection reasons, any clinical notes, any consultation notes, please make sure that they're clear, concise, professional, and appropriate. We don't want to see lots of exclamation marks and things in caps lock and unprofessional comments being made, because this data, this information is visible to the referrer. Really important, you've got standard operating procedure in place for all of these services as required in the service specifications separately. And make sure that you're delivering all of your patient-facing consultations, including those that you deliver remotely in your consultation room. Next one that's common for all nationally commissioned services, get your team involved. Make sure that all of your team know which of the services your pharmacy is commissioned to deliver. We've got around about 50% uptake across Greater Manchester of the smoking cessation service. Hypertension case finding, I think we're closer to about 80 or 90% of pharmacies. So make sure that your team know which services you're delivering. Service delivery is not just the pharmacist's responsibility. Identifying a referral is really important. Sometimes you might get a patient presenting in the pharmacy who has been referred, but it's not clear. They don't say the right words to you to understand that there is a referral. You don't want to lose your income for that service by treating that as an over-the-counter query. This is particularly for the CPCS referrals that are going to start coming through from urgent and emergency care. So making sure that your whole team, including those staff who work on the counter, understand which services you deliver and how to identify a patient who might turn up in the pharmacy who is a referral. As I mentioned before, your team should be checking farm outcomes regularly and flagging any referrals that need action to the pharmacist that's on duty, and almost holding that pharmacist to account to make sure that they've completed those referrals within the appropriate timescales. And making sure that your pharmacy is offering and delivering those services throughout the pharmacy's opening hours. Technicians, I'm sure you're all aware of the updates that came through earlier the year in April, May time. So technicians can now directly deliver smoking cessation service and hypertension case finding services, which is fantastic. So that just allows you to spread the load a little bit within your pharmacy. And also technicians can deliver the majority of the discharge medicine service. So if you do have registered pharmacy technicians in your pharmacy, please make sure that you're using them to deliver these services, to take the pressure off the pharmacist. Some other things that are common around all nationally commissioned services is local engagement. Your success or otherwise in delivery of these services is going to be based on the relationships that you have with general practice, hospitals, and other key stakeholders. So engaging with your local practices and PCNs is really key to maximising success. So for GP CPCS, the practice needs to be reassured that you're going to do something with those patients who are referred. They won't keep referring patients to you if you don't pick those referrals up, because what happens is those patients then go back to the practice to complain that you've never followed up the referral. They lose faith in the system and they will stop sending referrals. So you need to pick those referrals up. But it's a two-way process. So do talk to the practice about referrals that they've sent. If there's any escalations that you've made where you felt things could have been managed differently, if you've got any inappropriate referrals in the first place, so maybe you've had a child under the age of 1 referred, which is outside of the service spec. So have a two-way communication channel with the practice around GP CPCS and really make that service work for both of you. With regards to hypertension case finding and contraception, for both of those services, you need to make sure that the practices and PCNs, first of all, are aware that you're providing those services. And also you need to have those local conversations about how referrals are going to work. What's your capacity to receive them? How are they going to refer patients in? How many? So you need to have those local conversations, particularly around hypertension case finding and contraception. With DMS, again, the relationships with your local GP practices are really important. So if you pick up any issues at stage 1 or particularly stage 2, you need to be feeding those back to the practice. So talking to them about DMS and how you can work more closely together to improve the process for the patient is really important, particularly if the first prescription that's issued after discharge is not correct. And for the smoking cessation service, hospital cure teams, again, need to be reassured that you're going to support patients who they've referred on their quit journey up to 12 weeks. They're really open to you as community pharmacy being in touch with them. They want to know who you are. They want to know that you're going to look after their patients. So please get in contact with them, build a relationship with them. They're really good people. Diane and I have spent an awful lot of time with the cure teams across Greater Manchester, and they're incredibly passionate about what they do. If you can't accept referrals for a short period of time because somebody's on holiday or off sick or whatever, tell the cure team they won't send referrals to you for that short period of time, and they will welcome that contact from you, because it means it shows them that you are actively picking up those referrals and doing something with it. So really think about the relationships that you've got in place with all of the different parties who refer into community pharmacy for these services. I'm going to hand over to Lou now, and she's going to talk to you about the discharge medicine service.
Hi, good evening, everybody. And thank you, Alison and Lovejet, for a great start to the webinar. Really good introduction, which highlights the reasons that we're here tonight. I'm going to cover DMS and hypertension case finding service with a real focus on some of the issues that we're seeing locally. Next slide, please. So starting with the DMS, really important message in this slide is that DMS is an essential service. It must be provided by all pharmacies. It's not optional. There's no get out of jail free card on this one. You've got to do it. We are aware that some trusts are not yet making referrals, but work is underway to get these trusts live over the next 6 months or so. So you may start to see an increase in some areas of the number of referrals that you receive. Looking at the data, we do know that on rare occasions, there are some referrals for patients that are not eligible, and that you need to reject those back to the referring trusts. If you do have any ongoing problems with that, please do let us know and we can feed that information back in. The aims are there on the screen, but with DMS in summary, The aims are to reduce medicines-related harm for patients when they're discharged from hospital, and that involves working with everybody. It involves working with the patient, the hospital pharmacy team, GP practices, PCNs and practice pharmacists as well. Next slide, please. So as a contractor, as we've been saying all through the webinar so far, all services should be a team effort. It's really important that everybody gets involved. There's a role for everybody to improve outcomes for patients and to maximise the funding for your pharmacies. It's really important that your staff know the services you provide and their role in the delivery of them. So with DMS, like we've been saying earlier, it's really important that pharma outcomes is being regularly checked, and pick somebody in your team who you know is going to be diligent, who you know is going to actually do the task, and you know is going to nag you until it's done. Very easy to forget in a busy day that, you know, you've been told to do something, other things happen. Get somebody in your team who's going to keep reminding you to do that, and really work with those people to maximise delivery of your services. They need to keep alerting you all the way through until those initial stage ones are completed, and that must be within 72 hours. Next slide. Oh no, sorry, keep on that slide, Alison. Sorry, missed a bit on there. Sorry. We do recommend you've got a place. You recommend you have a system in place so you know when stage 2 and stage 3 are completed. Lots of different ways of doing that, and I'm sure you'll all find your own ways to do it. But some people prefer paper-based systems where you've got something really visible to you. And others may prefer flag on a PMR or just regularly reviewing any partially saved provisions in pharma outcomes. Like we said, DMS can be provided by locums and relief pharmacies. There's no excuse at all not to do it. And any failure to deliver this being an essential service is a breach of your NHS terms of service. So really important, if you don't want to be referred at some point to the Pharmaceutical Services Regs Committee for a breach notice, really important that you're reviewing your referrals and you are completing them. The programme team, like we said, are monitoring those now, and they will be in touch with you if you've got referrals that have not been started initially as a prompt, and just to try and help you out. As we said, you know, the LPC are here to support, so please do get in touch if you've got any problems, issues, concerns, questions, and we're more than happy to help. Next slide, please, Alison. So looking at the 3 stages of DMS, the really important message here is that DMS is a 3-stage service, and the expectation is that you complete all 3 stages. We know there's occasions where a patient may have change of circumstances following a stage 1, such as a return to hospital or a moves out of the area, but every effort should be made to complete all 3 stages. And a quick summary of them are that stage 1 is your discharge referral being received in the pharmacy. You're going to check that, check you've not got any outstanding prescriptions in the system. Stage 2, the first prescriptions received following discharge, and you're going to do a check against the discharge summary and highlight any discrepancies there to the GP. And stage 3 is where the patient's understanding of their medicines checked and any other services are provided alongside, and that could just be a return of unwanted meds, or it could be an NMS. At that point, you'll communicate any issues back to the GP. What we currently see with the DMS service is that pharmacies in general are quite good at completing stage 1, but completion rates at stage 2 and stage 3 tend to drop off considerably, with a very small number of patients really getting through all 3 stages at this time. As you can probably guess from the stage 3 requirements, that's a really important part from a patient safety point of view. It reduces harm, it reduces hospital admissions, and some of the trusts are now looking in the data in quite a lot of detail and trying to identify where the problem points are, either within the hospital or within general practice. So it is really important that we try and get through all of those stages. Next slide, please, Alison. Thanks. So looking at recording of information, the service should be recorded on pharma outcomes, ideally recording that at the time of each provision of each stage. There's a partial save function that's been built in, so that makes it quite easy for you, and those partially saved referrals will stay at the top of your services screen within pharma outcomes, so they can easily be retrieved for the subsequent stage 2 and stage 3. Next slide, please. So looking now at the 3 referral responses, and this is quite important across all services, but with DMS, you've got the 3 options there. You've got complete now, And that is where you're going to accept the referral and you're going to intend to complete that stage 1 straight away. The second is the accept, where you acknowledge receipt of the referral in Pharm Outcomes and it's in a pending state prior to completion of the stage 1. And just remember with that, you need to go back and complete it within the 72 hours. And that's the bit that's really helpful, as Alison mentioned, to the programme team, so they know that you've seen the referral and that you intend to do something about it. And the final option is to return. It's the way you want to reject the referral, and it'll send the notification to the hospital confirming the reason for rejection. So please do ensure you select the correct rejection reason from the drop-down menu, and you add any additional notes as required. Next slide, please. Here are some of the rejection messages that we've seen. So these are actual things that are being written into the rejection messages that have gone back to the trust. And we just wanted to highlight here some of the things that maybe that could have been done differently for these particular patients. So the first one we've got there is don't do DMS. As we've already said, it's an essential service. It's not one that you can opt out of. So the pharmacy there should have been completing their DMSs. The next one is patient is in a care home. This isn't a reason not to do a DMS. If the patient would benefit, then the referral should be completed in the usual way. Outside of 72 hours is one that we see occasionally. Again, as we've said, it's really important that a member of the pharmacy team is reviewing Pharm Outcomes throughout the day and alerting the pharmacist, so that stage 1 is definitely completed within the required timelines. The next one is the patient is not registered here and has never received any care from our pharmacy. What we would like you to do in these kind of situations is to try and find out which pharmacy the patient does use and make an onward referral to that pharmacy if you can. A really common one is the not a tray or blister pack at patients. DMS is not a blister pack only service. Although we do know that some trusts have prioritised that patient group for referrals. Pharmacy staff at the hospital are going to assess if patients will benefit from a DMS, and that could be for any reason. Common ones are high-risk medicines, non-adherence, 5 or more meds, elderly, confused, frail, but they don't have to be a blister pack patient. And the final one that we've put on there tonight is orders own medicines. In this case, a DMS should have been completed. Prescription ordering isn't relevant to the delivery of the DMS service. Next slide, please. And on to the final slide for DMS. I'm hoping that all of you are already aware of this, but I thought it was worth adding in because it was life-changing for me at the pharmacy that I work at. This is around claiming for DMS. We know that Pharm Outcomes doesn't currently link to NYS for the service, and that transfer of data is frustrating. We know that some of you are doing the work and not making claims at the end of the month, and you're missing out there on valuable income for work that you've done. So what Pharm Outcomes have done to help while the IT integration is sorted is provide a separate report that you can pull each month from the reports tab. And this summarises the info that you need to transfer into NYS. It does make the process much quicker. So if you aren't already using this report, please do have a look. It's really simple. Firstly, click on the reports tab, look for the local bespoke reports in the orange section on the left, click on the DMS manual claim report, select the month you want. It'll run the report in a few seconds, and then you can just use that report to copy and paste across to NYS. So do give that a try, really worth doing. Next slide, please. Thank you. Hypertension case finding is what we're going to cover next. Next slide, thanks. So this one here is an advanced service. So it's one that you could choose to sign up to, unlike DMS. And you'll either be signed up, individually as an independent or by your head office. It's a free service to patients, and it shouldn't be confused with any private services that you may have in your pharmacy for blood pressure checks. And there's 2 parts to it. So there's stage 1, which is identifying people at risk of hypertension aged over 40 and offering them the opportunity to have their blood pressure measured. That's a clinic check. And then there's stage 2, which is an ABPM being offered if a patient has a high BP reading at stage 1. The important bit here is that the ABPM is not optional. Every patient with a high BP should be offered and encouraged to have an ABPM, and therefore you must have that equipment available for your pharmacies. What we currently see from the data is that a large number of patients are not offered ABPM, and that some of those that are offered it and want it don't seem to get it. As with DMS, the programme team are now starting to look at the data in more detail, and they'll be contacting you if you're not delivering within terms of the service spec. I think more concerning for us as an LPC is that we're starting to see significant numbers of complaints coming in for general practice who are saying that pharmacies aren't delivering the service as it's intended. So please do be aware of that. Please make sure you've got the equipment, and please make sure you're carrying out both stages where it's required. One important patient safety point that's within the spec is that if a patient does fail to attend a scheduled pharmacy appointment to be fitted with their ABPM, the pharmacy team should make at least 2 attempts to contact that patient on separate occasions to rearrange the appointment. If the patient still fails to attend, the patient's GP practice must be provided with the initial results and notify that the patient failed to attend to be fitted with the ABPM. So that's really important, that if you've got patients there with high BP, that we've not managed to complete that ABPM because they've not turned up for an appointment, the GP is told that that has happened. Next slide, please. So following a very high or high reading, patients should be referred to the GP for additional care. We recommend using Pharm Outcomes to record all your provisions, because that will automatically send your GP notifications for you. And you should follow up with a GP by phone if a patient has a very high BP reading. Really important that those patients aren't missed. Next slide, please. This slide here covers the key actions that support service delivery. So first, please speak to your practices, make them aware that you're delivering the service and how you can work together. Make sure you've got all the required equipment available. Be aware of NICE guidelines for equipment, for BP readings, and for promoting healthy behaviours. Meet the IT requirements, including provider pays, and have a suitable layout of your consultation room. It means that blood pressure readings can be taken accurately. And finally, know when you need to telephone the patient to escalate them. Telephone the GP, apologies, to escalate them. Next slide, please. So on to promoting the service. Community Pharmacy England have made a range of promotional materials available, which you can use to display in the pharmacy. So there's a link there for you, and we'll share the slides later. There's also a pharmacy team briefing there to work with your wider team. And there's a virtual outcomes module that we've made available as well to support your staff. Try using some word of mouth, encourage your patients who've had a BP check to talk to their friends, relatives, etc. Provide them with a service leaflet that they can share as well. And use the promotional material in the pharmacy to start conversations when people attend for self-care advice or for buying OTC medicines, etc. Next slide, please. The final part of the service is the GP referral. So general practice teams can refer patients to a pharmacy for a clinic check or an ABPM. And these requests can be for patients with or without a diagnosis of hypertension. And these patients can be taking blood pressure medication. In Greater Manchester, GPs using EMIS can send referrals straight to Pharm Outcomes. Referrals can also come in via NHS mail, a text to a patient, or any other arrangements that have been made between a pharmacy and a GP practice. All service provisions should be recorded on Pharm Outcomes, either as part of the referral template or as a manual entry. And what's really important is that the community pharmacies and GP practices discuss how the service is going to work at a local level, and that GP practices understand the capacity you have to accept referrals. So if you can accept 10 referrals a week, tell them, let them know that you can do that. What we don't want them is only sending 1 or sending 100. It's really important that you have those local conversations, because every pharmacy will be different as to what they can manage within their general working week. Next slide, please. Again, the referral responses are really important, and similar to DMS, you've got complete now, accept and return. With hypertension case finding, we do see a small number of incorrect referrals, usually where it should have been a GP CPCS. And that's the practices that are using EMIS, who have got different buttons that they can refer to you using, and they just clicked on the wrong one. Usually it's a one-off, but if it does become a regular issue at your pharmacy from a particular GP practice, please do let the GPs know, and hopefully they'll work with you to resolve that problem. Next slide, please. And my final slide is looking again at some of the rejection messages that we've seen in pharm outcomes. So patients not on BP medication is patients on BP medication is a common one. So the difference here is between the case finding and the GP referrals. Case finding, patients cannot be on BP meds, and GP referrals, they can. So a referred patient can be on BP medication. Issues with ABPM access is probably our biggest problem. We get lots of reports of ABPM's not available, or that our machine is broken, or we've no machine at all. If you don't have access to the equipment, firstly, if you're part of a multiple, speak to your area manager, try and source the equipment for your pharmacy. But if it's not available, and it's not going to be available for some time, you need to temporarily deregister from the service via NYS. Unable to fit patient into clinic, they can only come in the evening was one we saw, and we see others that are similar to this. It gave the right information back to the practice, but it could have been a bit more, you could have provided some more information there. So for example, if you know that there's a pharmacy providing the service locally, it's open later, let the practice know, make it easy for them, and work together so that we're getting the right patients to the right place. Closing in 20 minutes was a one-off, I think, and I hope. But unlike things like GP, CPCS, hypertension case finding referrals don't need to be completed the same day. In this case, the pharmacy could have contacted the patient and made arrangements for them to come in at a more suitable time. The next one was a little bit confrontational in the way that they wrote it. And they wrote, as we have said before, we currently do not have a pharmacy manager, so cannot offer this service. Now, what the pharmacy should have done in this instance is initially told that the practices that they couldn't provide the service, but they should have deregistered as well until the new manager was in place. Another one here around ABPM issues, that's patient going to a different pharmacy, there's no ABPM available. Again, to provide the service, you need to have the equipment in place, or you need to deregister. And the final one is no consultation room or private area. And what we know in GM is we've got a very, very small number of pharmacies who have an exemption from having a consultation room due to the very small size of their premises. Unfortunately for this service, a consultation room is required, and therefore the pharmacy would need to deregister. But like I say, that's very small numbers. And I'll hand over to Diane now for her parts. Thank you.
Hi everybody, I'm going to talk about CPCS. Next slide please, Alison. So for those of you who need to remember that CPCS started in 2019 with 111 referrals. That was for minor illnesses and for urgent medicines. And then in 2021, it went to GP CPCS referrals, and these were just for minor illnesses to help with the GP practice pressures that they were going through at the time, and hopefully helping pharmacies to help give patients support that they need for their conditions. And now we've just actually started to roll out the more recent one of UEC, which is the Urgent and Emergency Care Centres. So these are for minor illnesses and urgent medicines. And in GM, we've just rolled out Rochdale Urgent Care Centre for this service, and they started on the 4th of September. And currently in their first week, I've referred 30 patients, or plus 30 patients. I've been referred into pharmacies, so this has been seen as very positive from the Rochdale team. We've had very good feedback from that today, so that's really, really good. And obviously the aim for CPCS in general is to hopefully to re-educate patients so that they know where to go to for their healthcare requirements and needs. As pharmacy is very well fit to match that for them, being on the high street, very more flexible hours, much easier for patients to access than waiting for a GP appointment, particularly if it's only for a minor illness. Next slide please, Alison. Contractual responsibilities. So the contractual responsibilities that you've got here are all laid out here in front of you, but I'll just go through them anyway. Obviously, accepting referrals. The referrals must be available throughout the whole of your full opening hours. The team must constantly check for referrals regularly with their IT systems and NHS mail. at least with their NHS mail, a minimum of morning and evening before they close, just so that they can check if anything's there. But certainly from an IT perspective, you obviously, like we said before in previous comments, try and get somebody to nominate it from your team to take responsibility for checking that the IT system that you have in place. Temporary suspensions, obviously, if you have got temporary suspensions within your practice, make sure that the relevant people are all advised and they know where that information is and how those numbers are easily accessible, and have a recorded SOP available. Locums, if you've got locums, there's no reason why a locum couldn't provide this service. I'm going to add something else in this that the others haven't mentioned, in the fact that I think that, you know, if a locum doesn't provide this service, it's actually it's probably going to cause more problems to you as a contractor, because obviously as we're looking at this data, that's causing us issues. If the locums aren't providing it, then it has reflects badly on you as a pharmacy, unfortunately. So do bear that in mind when you're booking your locums, that they need to be aware that they can provide these services. IT support, make sure that obviously you're aware and your team members are aware of how to contact your support team and your IT systems in case you've got any problems with that. And make sure obviously if you have problems, that you're feeding that up to the relevant referral pathways, so that they're aware, GP practices and urgents, whichever referrals that you get through those services. And last for me would be provider pays. Obviously, I'm sure you're all aware that you've all had to have nominated somebody for your provider pay. You've got emails from myself if you still haven't nominated somebody, so that you'll need to sort of get on with that if you haven't done in the meantime. Next slide, please, Alison. Overview. So CPCS referrals come from 111. That's the telephony side of things. They also come from 111 online. We've got general practice for minor illness only, and obviously UEC, which we've mentioned already. The referrals from the GP should be contacted by the pharmacy within 2 to 3 hours of receipt of the referral, and referrals that are received by 2:30 must be actioned on the same day. The UEC referrals that are coming from the urgent care centre, slightly differently sent. They are actually the patients are going to present actually at the pharmacy, usually with some form of a letter or a document, piece of paper or something that will say to them that they've been referred. So it's really important that your counter staff are aware that those patients are identified when they actually get to the pharmacy, because they'll have been in the urgent care centre and they're not going to go home from there to make the phone call to come in, which is the same for the other services. They're actually just going to go straight to the pharmacy. So the chances are that they're just going to come through, so you need to make sure that you're identifying those patients. Bury and Tameside did participate in the pilot, but are currently not sending referrals at the moment, but they're going to be supported in a relaunch of their services the next few months, hopefully. As I said earlier, Rochdale went live last week on the 4th of September, and are very, very pleased with the services that's being received at the moment. And discussions are in place with Bolton and MFT with the potential to go live before Christmas. Next slide, please, Alison. So the consultation for CPCS is conducted, is supposed to be completed within 12 hours of receiving the referral. You should contact the patient within 2 to 3 hours. And obviously if the patient hasn't been contacted by the pharmacy, then the patient should actually contact the pharmacy themselves. I've said that the wrong way around, haven't I? Apologies. So the other way around. So if the pharmacy hasn't contacted the patient, if the patient hasn't contacted the pharmacy needs to contact the patient. Patient needs to contact the pharmacy, whichever way around it is now. I forgot, I'm losing my thread, apologies. So the consultation is to be completed by the pharmacist, and it has to be remote or face-to-face, whatever is considered to be appropriate for that particular patient. It's a clinical assessment, and obviously you've got your NICE guidance and your summary care records to check, and also identify any red flags that are there. Make sure that your outcome, you're using your safety netting advice, and if you have to escalate any of these referrals, that is the pharmacist that makes the call to that escalation, wherever that may be, whether that may be to out of hours or back to the GP practice. Next slide, please, Alison. Consultation outcomes. As I'm sure you're all aware, there are 6 outcomes for CPCS. The most important bit of information to share with you is 31% of all referrals have resulted in self-care advice only to patients. And that is obviously, self-care messaging is obviously an essential part of CPCS. So obviously most of these patients don't need to go through these other methods. So that's something that you as pharmacists and pharmacies do every day. Just to bear in mind the fact that non-urgent escalations the pharmacist must contact the GP when they need to signpost patients back to the GP practice for urgent or non-urgent. The pharmacist that must do that. They mustn't share the telephone number of the GP practice or expect the patient to do that. And Pharma Outcomes does not send escalations automatically when you save the consultation notes. Next slide, please, Alison. Recording information. So it's really important that you enter and complete the appropriate data into Pharma Outcomes, so that if you need to signpost or escalate your patient, then your notes will help you, the GP, to assess what is required. These are some good examples of these, good notes and poor notes. So just a couple of examples. Obviously, you've got here red flag symptom was a note that was given. From that, it will mean that the GP practice then, when they receive that, will then have to continue to do the consultation on the patient again. Whereas if you'd have put something more like the patient is asthmatic, cough not improved despite inhaler use and OTC medicines, also producing discoloured mucus, then that GP practice might just actually write a script for that patient for antibiotics. Again, if you say you can't sell or requires antibiotics, it would be better to put further information like they've had symptoms for 5 weeks, cloudy urine, associated pain. So I think it's just really stressing out to you that you need to really make sure that you're putting good examples of notes rather than just very brief. I know it's hard because we do understand how busy you actually are, but as Louise said earlier, that all the data as well that is entered into Pharma Outcomes and a consultation is visible by the practice or the cure team or the urgent care centre. So it's really important that it's factual and professional and information in there. Next slide, please. The referral process, much the same as what Louisa said. It's basically the same thing. So obviously with this, the patient's consultation has to be within 12 hours. You've got obviously your 3 options. You've got your complete now, which is where you receive the referral, you complete it straight away, and you can record the patient's consultation there straight away on Pharma Outcomes because you've got the patient in the pharmacy and they've arrived in that. They may have already come into the pharmacy or they're on the phone with them doing the consultation then. Or you can option for accept, where you accept the referral and it puts it in a pending state. And then you have the option to then, when you speak to the pharmacy, the patients, you actually get the patients to come in at an agreed time to you that you want them to come into the pharmacy. And then when you do that, you go back to the complete now and you can complete it on Pharma Outcomes and record the consultation. And then finally is to return, which is a reject. And the reasons for rejecting a referral is usually because you've not been able to contact the patient or the patient has declined. Uncontactable is probably the only reason to use reject is uncontactable, because for every other reason you should be able to assist them. Next slide, please. These are some of the reasons that we've had for the rejections on CPCS. So advised to take painkillers. This isn't a rejection reason, it's an outcome. If you've typed in advised to take painkillers, then you've already done the consultation because you've already advised them to take painkillers. So you've missed out on that fee that you would have received for that purpose. You've given the patient the advice that they needed. Better now, accurate reasons should be reflected about what happened. Next one is patient didn't want to buy meds. So the understanding that minor ailment service is available in the localities and what's available around in GM in other areas, because obviously you might be seeing patients outside that area who register with a particular GP, so they can come from different practices. So you just need to make sure that they get the right information for that, and just an understanding of what is available on our minor ailment service. Not completed by locum pharmacist on the day. Again, like we've said, all locums should be providing this service. It does reflect badly on yourselves as a practice if they're not, really. I can't say any more than that, having looked at the data, and I make the phone calls. Needs free drops for the minor ailments scheme, which they don't do here. Will complete the consultation and signpost the patient to where they can access the minor ailment service, or if you don't provide the minor ailment service and it's available in your area, then they'll sign up to the minor ailment service. Should have been a blood pressure check. Make sure you speak to the practice to re-refer the patient to the correct service, and the wrong telephone number was the reasons given. Just contact the patient, the GP practice, or and actually get the right details for the patient. It's not a reason to reject the referral. Next slide, please, Alison. The smoking cessation service now. Next slide, please. Okay, so the smoking cessation service is a service that's available to assist patients that are in hospital. They are advised by the cure team regarding their quit attempts is worked back through them, and then obviously they're referred then and chosen pharmacy as their pathway to get support with their quit. So the SCS service is to help with to reduce the health inequalities and for higher rates of the stop smoking to be an objective of the service, to sort of help with the pharmacies and to help the GM hit their smoke-free, making smoking history within GM. So it's really important that we sort of try and get that service run successfully within the referrals. Next slide, please, Alison. Contractual responsibilities. Okay, so all pharmacists must have an approved CO monitor. It's part of the requirement to do that. So there's a list on CPE website where it tells you which ones you can actually purchase. You've obviously got the NRT provision, which is a maximum of 2 weeks supply. And also you've got NRT products, maximum of 2. They're at no cost to the patient, regardless of their prescription status. Check the drug tariffs for all the included products within that. And NCST, the Stop Smoking Practitioner Certificates for mental health, e-cigarettes, pregnancy, additional email, e-learning modules are available. Practices should be have completed the behavioural support and NRT provision that's on the NCSCT standard treatment programme to be able to support all their patients through their consultations. The referral follow-up, the pharmacy must have at least 3 attempts should be made to contact the patient, the last of which must be on the 5th working day following receipt of the referral. So it's really important to do that, and we'll get onto that in a little bit further again in the next slide. And consultations, the initial appointment should be timed to ensure the patient doesn't run out of their NRT following discharge. Normally during discharge, they're normally given a week, maybe 10 days supply. So you really need to make sure that you are contacting that patient and getting that patient in for that first appointment within that time frame, so that we don't lose them within the service. For weekly or fortnight sessions, face-to-face or remote, for up to 12 weeks from the quit date. Next slide, please, Alison. This is a service overview. I'll just not to go through most of the things with that. It's just obviously that all GM trusts are actually live now with sending referrals. The Mental Health Trust and GMMH are also live in their Trafford sites, and the Pennine Care implementation is being planned looking forward. The Cure team are so passionate about this service and pharmacies providing it for them. I can't express how much they are, that they really are committed to their patients, and they really want the pharmacies are there. They're giving us the pharmacies an opportunity to help and support their patients, and they're really keen, like Alison said before, to be engaged with the pharmacies. It's really important that if you've got your local Cure team, that you're trying to contact them on a regular basis, because I think it's one of the Cure team, for example, really wanted to actually go out and visit all the pharmacies in her area, because she felt it was really important to get that connection. So I think it's really, really good to sort of keep that in mind, and obviously just ensure that if the pharmacy is commissioned to deliver that service, that you do follow up with the patients, are followed up in line with the service specification and given that behavioural support. And if you can't provide the service, then decommission from the service, deregister from the service, I should say, because it's really important that the Cure team know who can provide the service and who wishes to provide the service. Next slide, please, Alison. Recording of information. So the farm outcomes templates are all available to all the pharmacies to help them deliver the service. They're all linked for the process. So you've got obviously the initial intervention template following the referral and receipt, and this is linked directly to the referral that you've received. And then obviously there's then the interim appointment template to record the weekly visits. There's a 4 and 12-week quick template to record the patient's outcomes, and then there's an onward referral mechanism for you to send to another pharmacy if you need to do that. And all the claims are actually automated through Farm Outcomes, so they're paid automatically through that. Next slide, please, Alison. Again, the referral process, the referral responses are much the same. So again, you can accept the referral, which will leave it in a pending state while you contact the patient to arrange initial appointment. This is when you're making your phone calls and not actually getting through to the patient as yet, so you keep it in a pending state there for you. The complete now is when you need to go back into that to actually complete that referral with the patient. This only completes, you can only complete the initial appointment module when the referral has been completed. When completing the consultation with the patient, you need to record this in a separate module, which is the module that's the initial appointment module. And then there's obviously the reject, unable to complete. And then you need to make sure that if you are doing this rejection, that you're giving a suitable rejection reason for that response. Next slide, please, Alison. Reasons for rejection. We don't offer the smoking cessation service, no longer offer the service. If you don't offer the service and you can't provide it, then you need to deregister from the service. And that will help the Cure team to stop sending referrals to you. That's done by MYS. And then training not completed or no one trained to provide this service. So you can obviously do the e-learning courses if you want to do that. If somebody wants to continue to provide the service within their pharmacy, this needs to be completed, and the links are all there for you to actually do so. We're unable to do this service for a month. I think Alison has mentioned this before. If you can't do it for the month, then contact your Cure team, contact them and let them know, and they'll stop sending you those services for that month or for that 2 weeks, etc. So if you've got work pressures at that time, obviously you can't do it continuously, but obviously we'd rather the Cure team know to suspend for a short period of time to stop sending referrals through to you than use you to the service. Didn't contact. All patients must be contacted. Ensure that your health champion is there to assist with the patients. I think Alison alluded to this before. It's the actual, it's the team effort. They shouldn't all fall down to the pharmacist to contact the patient. The your counter staff, any of the members of staff can actually be arranged to contact the patients, any of the patients for any of the services, and arrange for them to sort of contact the pharmacist at an appropriate time that's agreed. It's about communication within your team. No regular pharmacist to provide the service, no manager to complete. If the service cannot be provided as specified in the service specification, then it needs to be deregistered. And the last one was just one that we had, was the patient. The pharmacist response was they didn't want to disturb the patient because he had been poorly and in hospital and was waiting for a medicine review. The patient had agreed to be contacted, therefore the pharmacist should have contacted them to help them with their quick journey. I think that's it for me. That's over to you. Thank you.
Thanks, Diane. So we've just got a very quick update on the contraception service, and then we'll stop talking and take any questions that you might have. So, as you know, contraception service was launched at the end of April, again as an advanced service. So pharmacies must register to provide this service. It is optional, but if they do register, they may receive referrals. We just want to flag that the service start date for contraception was not agreed with Community Pharmacy England. This service in particular is still subject to discussion under negotiations between Community Pharmacy England and NHS England, and those negotiations are still underway. So the service itself aims to provide people with a greater choice and access when considering continuing their current form of oral contraception. Ultimately, it will be a tiered service, but currently it's just tier 1 that's commissioned, and that's where supplies of oral contraception are made under a national PGD for people who've previously been initiated with oral contraception, either in general practice or in a sexual health clinic. General practice can refer patients into community pharmacy, and those referral mechanisms will be in the same way as GP CPCS through EMIS local services. Pharmacies should engage with their local practices and or PCN colleagues to make sure they're aware that they are participating in the service, and to discuss locally how those referrals are going to work, very much in the same way as we've advised you to do with the hypertension case finding service. We do have a number of pharmacies in Greater Manchester who have registered to provide this service, and we do have some activity. So this is happening, but we're not formally engaging or providing any formal implementation or support with this service until we get the results of that national negotiation, which is expected imminently. So pharmacists can register to deliver this service and they can deliver it, but the level of information and support that's out there is limited at the moment, just pending the conclusion of those negotiations with Community Pharmacy England. The Pharma Outcomes referral response table is the same as the other services. So you need to complete the referral in Pharma Outcomes to confirm that you've made contact with the patient and you've arranged an appointment. Accept puts that referral into that pending state. So it lets us know that you've accepted the referral, but you haven't yet made the appointment with the patient. And obviously the return is rejecting that referral. So please make sure you're using an appropriate reason for rejecting the referral. Okay. Well, thanks everybody. Really appreciate your attention and have a great evening. Enjoy the rest of your evening.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.
Bye.